Hello, I'm Dr. Cassandra Kelly-Serino with DNA Genotek, and today we were hosting a workshop in Cape Town, South Africa at the Union's 2015 meeting entitled Scaling TB Testing Networks, Challenges and Practical Solutions. We're going to be talking tonight about challenges that countries face trying to scale their TB testing networks and some of the things that we can do as practical solutions to help solve those problems. So thank you very much, and I hope you enjoy the session.
First, I would like to thank Cassandra to bring all the speakers together. And we certainly know how important scaling TB testing networks is. And of course, whenever you do something new, there are challenges, and hopefully we also learn from the practical solution that impact the case detection rate. The objective: understand the main challenges in scaling and standardizing TB testing networks, discuss potential solutions to overcome these challenges, and third, discuss tools to impact algorithm adherence and cost reduction and to decrease time to result. When you look at these four speakers, their first names either starts with an A or ends with an A, and that is proof that is really an A team we have assembled tonight. Just a few introductory slides from my side. Promoting healthy outcomes starts in the beginning with maintaining health. It's the individual's responsibility, recognizing symptoms, and in this particular case, TB symptoms, seeking care. As healthcare provider or laboratory scientist, we don't have any impact here. Then the community has also a responsibility to provide access to care. And then, of course, when you are within the system, the healthcare provider needs to be suspicious for a TB, ordering correct test, prescribing adequate regimen, and ultimately public health kicks in with overseeing medical care and assuring therapy completion. And only then we have a healthy outcome. So it's a team sport, and it's very important that everybody plays its role. In terms of TB laboratory methods, I won't go through all of these, but we know all some of the testing methods we use and still use are more than 100 years old. So we really need to make sure that newer technology is implemented as quickly as possible so we can do our job as laboratory scientists to end TB. But even if we have sophisticated, high-tech laboratory assays, if your sputum is not good, your result will also not be good. So we have a saying in the United States, garbage in, garbage out. So it's really important to focus on the quality, and even more so when we implement molecular technology, because everybody thinks this is the magic bullet, but if the quality of your specimen is bad, the result is also bad. Sample quality criteria, I just pose here 3 questions. Purpose for collecting, processing specimen. It really matters for which purpose we actually collect that sputum. Is it for molecular, is it for smear, or is it a culture? Availability of networks, or other people say fast-track programs. I was a session before where in one of the African countries they demonstrated with a transportation system that they actually were able to cut turnaround times from 3 weeks to 1 to 7 days. This is when you have a systems approach. And lastly, I would say this is a new field for us, need for a transport medium. As we ship specimen more around, we need to look, is this what we're currently doing really the best way? Everett Rogers was a farm boy. He recognized, and he published his observation in the 50s, so more than 50 years ago, that there are always innovators. There are early adopters. If you consider the cell phone, how quickly the cell phone, everybody has a cell phone today, and in terms of innovation, the phone is no longer only a phone, it's a calculator, it's a flashlight, and many more, and a camera, and many more things. So here again, the innovators, and then how quickly are you actually adopting a new assay? And then early maturity, late maturity, and hope. Nobody in this room belongs to the last categories, the laggards. That's all what I wanted to say. And now my fellow co-chair will have also a few words.
Thanks again to Cassandra and her team for the invitation today. My job here today is just, in 2 minutes, give you some food for thought. And I'm Lindsay Isherwood. I'm from the National Health Laboratory Service in Johannesburg, South Africa. And we manage over 80% of the country's pathology results. So with that said, I'm going to just re-emphasize how important the pre-analytical phase is of any lab specimen. Right from specimen collection and specimen preservation all the way through to specimen processing. So just to give you an idea, and this is based on an HIV program, that when you do implement any type of program, diagnostic program in your country, you must look at the model that is intended for. So you've got to look at the prevalence of your disease and the application of where it's going to be situated. So you can have very low, very high centralized labs, and then you could go to an HIV viral load labs where it's sort of semi-centralized, and then you can do decentralization like our Xpert program. So you need to choose a service that matches your scale, and you need to extend your existing laboratory footprint to improve the access of those in remote settings. And you must also look at the niched approach of your testing. So you must include your point of care, your viral load, your early infant diagnosis, your TB. So you have to really look at polyvalent sort of assays as well. And you must also replace your existing technology with a broader footprint and more sensitive technology. So if you really are going to make an impact in your country, it has to be all pre-analytics, and the sensitivity has to increase of your assays as well. Thank you.
My title is Challenges in Implementing Efficient TB Diagnostic Network at the national and supranational level. And this is a perspective from the supranational reference laboratory. We are definitely changing the paradigm for TB and MDR TB control, and I think this paper that came out in Lancet Infectious Diseases very recently is pointing this out very clearly. We were used to networks that were focusing on smear microscopy. Until a few years ago, I was visiting the country. The assessment of the network was the smear microscopy network. Things are changing because of the MDR, because of the implementation of new diagnostics, but it's also clear that with this new paradigm of high rate of transmission of MDR, so the majority of the MDR cases in some countries are not due to the mismanagement of TB cases, but to the transmission of MDR, is calling for new action. And among the new action is definitely the universal screening for drug resistance, because you need to start treating your patient correctly from the beginning, and then implementing better drugs and shorter regimens. Having a good data on drug resistance will allow to use the drug according to the drug resistant pattern. So we are moving from GeneXpert for all to a more sophisticated universal DST. That is also the vision of the NTB strategy. The integrated laboratory network is also evolving under the WHO recommendation. In the Stop TB plan 2015, that is ending this year, they were calling for 1 microscopy center per 100,000 population, 1 culture lab for 500,000, and then 50% of the patients with the new patients and 90% of the previously treated with molecular tests. But now the NTB strategy is calling for universal DST. And universal DST, of course, will probably be molecular on the first approach, but we are not forgetting the role of the cultures. In order to control tuberculosis, we need to test the people that may be suspect in the population. We are not supposed to use the word suspect, but with my poor English, that's the first word that comes up all the time. And move to the test site and then identify the people that needs to be treated and treat them. How easy is this? Well, it's not easy because we want to get to the people, so we need to move the testing, at least the first level testing, to be completely decentralized in order to improve the time to diagnosis and start treating. In an integrated laboratory network, what do we want? We want one-stop shop in which we have all the primary diagnostic services, not only for TB, but really for HIV and malaria, and also the basic screening that will support in general the health system strengthening in all countries. But what do we need to remember is that we cannot implement all tests at all levels. So we will be implementing the most decentralizable test at the community and the healthcare center, in some places at the district level, such as the gene expert, and then we can move to culture and DST at the regional and the reference level. The rollout of Gene Expert was a real success. From 2011 to 2014, a huge number of experts and cartridges were used all over the world. Unfortunately, and that came as a surprise, it didn't have the impact we expected on the patient outcome. But why is this? Because just putting a new tool in one setting that is not ready to receive the tool, doesn't have the infrastructure, doesn't really make the impact that we are looking for. So there are several reasons, and we are not going to comment on those tonight. I will stay focused on what is the scope of this evening. One of the reasons is that we need to move either we move the patients, and this is very hard and costly, or we move the specimen. And in order to move the specimen, we really need to find good system to move the samples around from the health post to the peripheral laboratory, to the intermediate laboratory, to the national reference laboratory, in order to provide to the patients all what is needed. So the first step is to be able to find a network that has a system in place that can move the samples efficiently around the network. And this is where sometimes we fail. And we fail for many reasons. We fail because there is not one system in place, because the organization is locally managed, because the system is not, because there is a delay. The test itself is fast, but there is also a delay in using the test. Because the turnaround time for a test for TB detection is not the time that the machine uses to give you the results from when you start loading the machine. It's the time that goes from when you collect the sample to when you are giving the results to the patient. And the first step is to avoid to have a 5, 6, 7 days delays because you don't know how to move this sample around. But once you have found a good system that moves the sample around, you also need to make sure that your sample arrives at destination without losing its quality. And this is an additional factor that is very important. We also say in Italy, garbage in, garbage out. But what I would like to add is that the laboratory knows that the garbage gets in. What often is not clear to the physician is that he's getting the garbage out, because we not always write on our reports, look, we got garbage, so this assay is not reliable. A false negative, a contaminated result doesn't really mean anything because the garbage came in. It's very important to have a good specimen referral system. The results of the test are affecting the patient diagnosis and treatment, and they are definitely related to the quality of the specimen that is collected. When, as a supranational and working with the National Reference Laboratory, we find out this. When we look at the rate of contamination, 1 minute. I thought I had 15. I still have 6. But I can do faster than that. So it's when we look at the rate of culture contamination. The rate of liquid and solid culture contamination is directly proportional to the lag time that has been used for the transport of the samples. And also in the components of a high-quality network of laboratory, the mechanism for specimen collection and transport are a key point. The laboratory asks for a sputum sample that needs to be delivered without any delay, and this is not possible. It's not possible in the majority of the cases. When we are lucky, our 24 hours can be 48, can be longer than a week. What they recommend is the use of acetylpyridinium chloride in 2% sodium chloride solution to diminish the contamination rate. But there are disadvantages. Once you have specimens that are half in CPC and half not in CPC, people get confused because they cannot keep them in the cold. Because if those specimens are kept in the cold, then they become very problematic. And this is definitely not the best transport medium for doing liquid culture. So we need novel technology to improve the sample collection and the transport to simplify the laboratory processing. And why we need them? We need them to increase the critical diagnostic services in the country, culture. Even if we are implementing the molecular network, molecular diagnostic network, we still need to move the positive samples to a culture laboratory to move on. And this is why sometimes we do not get second-line testing results, because the sample just doesn't arrive to the laboratory, or if it arrives, the culture is contaminated. Out of country, we need to do a lot of retesting for EQA purposes. Now we are supporting the countries with large NGS and VGS study, and we get cultures that are contaminated most of the time. Or sometimes we can really not have good quality of samples if they need to be shipped internationally. The OMNIgene came with this product. We have evaluated this product very preliminarily, and we found that it is in effect compatible with mere microscopy. is compatible with culture in midget up to 10 days of storage at room temperature in my laboratory, has been verified on Xpert, is compatible with LPA. We haven't done VGS for now. The studies that are now ongoing are a collaborative study with the SRL, my SRL and the NRL in Tirana, in which 350 sputum specimens will be processed with and without the OMNIgene SPUTUM transport medium. They will be shipped in Milano by plane. In the maximum time of 10 days, they will be set up in culture and the hind test will be done. In parallel, Tirana will do the routine testing by decontamination protocol, midget and hind testing. So we will try to evaluate what is the effectiveness of this transport medium that we plan to apply on a larger scale, and what is the maximum survival time of MTB in this transport before it can be put on culture. We will also try to use this transport medium for our VGS study. So we will try to see if then we can use the reagent for DNA extraction, and that is suitable with our Illumina protocol. In terms of future perspective, one of the biggest problems we have is to do the DRS in countries with very little culture capacity. So we are doing the DRS using the Xpert, and all the rifampicin resistant will need to be cultured. So to do culture, they will need to be transported first at the National Reference Laboratory, but some of them will need to be transported in Milano. So we are trying for the first time to apply this system of transporting sputa to the National Reference Laboratory and then to Milano to see if that will give us better result compared to the last survey. The last survey in Burkina was really problematic because we could not retrieve the number of culture that were requested for the survey. So at the end, I'm concluding here because we are looking for something that is stabilizing, liquefying, and contaminating our sputum sample at the point of collection that is compatible with the existing and future TB test that can simplify the process. So I can explain the country when I give the survey protocol that is only a simple laboratory procedure, and then they can keep that and they can avoid to ship every 3 or 4 days, and now I'm done. And that will also eliminate the cost or complexity of the cold chain shipment. And said so, I'll thank you all.
So first of all, I would like to thank the organizers for inviting me to talk about this important issue. So I'll talk about the constraints and challenges which a country with a resource limited setting has to face regarding specimen transportation. So I'll give you a brief background of the country and how does the patient and specimen flows in the laboratory network, and why do we need a specimen transport, and what progress and achievements we have achieved up till now, and the constraint and challenges, and how do we see what is the way forward to improve this. So Pakistan is a country with a 185 million population, and it is divided into 5 provinces and 3 regions, and it has 140 districts. So if you look at the map, we have, on average, we have 225 people per square kilometers, but it is not uniformly distributed throughout the country. So if you look at the map at the province 1, which has a population of 99 million, in contrast to province 4, which has a larger surface area than the province 1, but with a population of only 8.9 million population. So this province is really difficult even for the specimen transport, because It's very much underdeveloped. The density population is very scattered. So we have, every province has its own challenges. And the graph over here down is showing the temperatures, which are what are the average temperature for most part of the country. So the average temperature for most part of the country, you can say around 6 to 8 months. It touches, the average is 35 degrees centigrade, and for 2 to 3 months, it would touch above 40 degrees. So its temperatures are really challenging for the specimen transport if it is kept at a room temperature. And secondly, we are also facing quite a lot of power shortages. For the large cities, it's around 8 hours that we don't have any power, and for the smaller cities, we don't have any power for 10 to 12 hours. Coming to this, what is the disease burden? So we have an incidence rate of 272 per 100,000 population, which comes to around 500,000 TB cases every year. In year 2014, we notified 316,000 cases, and these cases were notified. The blue bars in the figures represent the functioning basic management unit for TB. So we had, in year 2014, we had around 1,400 basic management units. And of the total cases notified, around 110,000 were smear positive, the same 110,000 were smear negative, around 52,000 were smear extrapulmonary, and 14,000 were retreatment cases. Highlighting these, that when we implement some policies, so you should have that if you go for universal DST, even in phases, what would it mean that how many people need to be tested? Coming to the MDR, among the cases notified in year 2014, we had estimated 11,000 MDR cases in this population. And programmatic management of drug-resistant TB started in year 2010 in Pakistan, and now we have around, by the end of year 2014, we had 24 sites offering programmatic management of drug-resistant TB. And year 2014 alone, 2,651 MDR TB cases were enrolled on treatment. So how the laboratory services are arranged? At the most peripheral level, we have the microscopy laboratories, which are now more than 1,400. At the intermediate level, we have Xpert. In year 2014, we had 66 Xpert sites. We had 8 culture labs and 4 DST labs in year 2014. But we are very much optimistic that by 2017, we would have 7 DST labs, we would have 16 culture labs, we would have more than 110 Xpert sites, and the microscopy network would also expand. So how does patient flows from within the laboratory network? So when a patient reaches the first basic management unit, and if he is identified at risk of MDR or he is identified otherwise eligible for Xpert testing, the specimen need to be transported to the Xpert site. Either the patient goes himself or the specimen is transported depending on the facilities or the system established within in that facility. If the patient is identified as rifampicin resistant, he is then referred to the site for the programmatic management of drug-resistant TB. On enrollment, his specimen is collected and is transported to the DST laboratory for first and second line DST. The patient is cared under ambulatory care. He comes to this PMDT site every month, and the specimen is collected at this site and then shipped to the culture laboratory for treatment monitoring. So we have entirely 2 different groups of patients who require specimen transport. One are the ones who are enrolled for DRTB treatment, and their specimens need to be shipped for culture and DST. The second group of patients are those which are at risk of DRTB, and their specimen need to be shipped for Xpert testing, or otherwise they are vulnerable and they need to be we need a better, more sensitive diagnostic tool for testing for diagnosing TB. So what we have, how much have we progressed, and what are the achievements till date? So culture and DST services in Pakistan in the public sector is not a very is not a very old history. We just started culture and DST in 2009, in last quarter 4 2009. And in that quarter, the laboratory, the main national reference laboratory, which established in 2009, was linked to the health facility within the same city. And the staff from our laboratory used to go in the motorcycle and collect the specimen from that facility. Between 2010 and 13, we conducted 2 large surveys, which was a really which was a rich experience in the specimen transport, because the specimens were collected across the country from various clusters. And then from 2012 onward, the laboratory was linked to the PMDT site because other laboratories were not yet functional, and this laboratory was providing culture and DST services to the newly emerging PMDT sites. In 2014, we started linking BMU to the Xpert site for the Xpert testing. So I will talk first about the culture and DST services. So altogether, we have planned to have 30 PMDT sites and 22 culture and DST laboratories. So this specimen transportation would mean movement of specimens from these culture DST laboratories, from the PMDT sites to the culture and DST laboratories. All these PMDT sites are located in the larger hospitals, so the courier services are more, their presence in these cities is more established. And we don't have as much of a problem in transportation of the specimen from the PMDT sites to the culture and DST laboratories. The specimen is transported in the cold chain, and the courier service is hired for these services. So this is what is shown, that this is what we did in the 2009 when it started, that a person he still goes to the health facility to collect a specimen. And then subsequently, we had a drug resistance survey, and we were getting samples from different clusters. And now we are getting samples from the PMDT sites, which are located in cities, in other cities, not in the city, in the same city as the lab is. So what did in this diagram, what you see is the number of specimens which we received through specimen transportation. The pink part represents the specimens which were received from other cities. The violet part is showing the specimens which were received from survey or surveillance, and the blue one is the specimen received from the same city as the lab is. So altogether in 2014, we received 19,000 specimens, and these 19,000 specimens were 45.2% of the total specimens processed in the country in this year. So what are the challenges and lessons learned in the culture and for the specimen transportation with regard to the culture and DST? That you need to have a very effective communications and coordination between the referring sites, courier service provider, and the TB culture and DST laboratory, and without this, it will not be possible to have good results. Then sensitization of the clinical staff is equally important as training of the laboratory staff. Otherwise, the clinical staff will collect the specimen and will keep them in the ward or in the hospitals before transferring to the laboratory. And we saw that with effective coordination, 80% of the specimen can reach laboratory within 72 hours. However, we also noticed during the survey in the specimens that the specimens which reached within 72 hours contamination rate was around 11%, and the specimens which, for which the transport time exceeded 72 hours, contamination rate exceeded to 24%, depending on the month of the month and the site from where we are getting the specimens. And we don't have any system in place for temperature monitoring of during transportation. And we have 3 good courier services with good coverage, but all are not interested in carrying an effective specimen for transportation. So most of the time we are left with only one courier services who is ready to provide us services, but then he monopolizes his situation. We have a good national postal services with a very good coverage, but they have declined to carry the infective specimen. Coming to the second part, the second group of patients who require specimen transportation is those who require it for Xpert testing. And yes, we need specimen transport for Xpert testing because Xpert sites are few and the patients are scattered all over the country. And if we have to provide equity of access to these new diagnostic tools, we have to establish this specimen transport. So we need to link, develop, establish linkages between BMUs and with the Xpert sites. So the plans to establish linkages between the Xpert sites and BMU is in progress, and the contract has been established with the courier services, and logistics have been procured, distributed, and specimen transport in cold chain from BMU to Xpert site is taking place. This is how the system takes place, that the courier services only operates at the district level. Their presence at the sub-district level is, we don't see their presence at the sub-district level. So when a patient comes to the basic management unit, this specimen has to be transported either through some local arrangement, or the patient himself or the attendant himself has to carry it to the district level. From the district level onward, if the Xpert facility is available at the district level, it is tested at the district level, or it is carried by the courier services to the Xpert site. So the challenges are that the country with 1,400 basic management unit with microscopy services have few Xpert sites. And we don't have an established referral linkages. So it's a TB program taking an initiative, developing these referral linkages. And however, because the laboratory network is expanding, every time we have new laboratories being functional, we have to revise our linkages. And then there is extreme temperature, infrastructure is not very good, and we didn't have any specimen transport mechanism existing within the health system on which to build upon our specimen transport. So it's a new initiative that we have to build this system from the very scratch. And what we saw that with best of effort, only 70% of the specimen reached laboratory within 72 hours. So for most of the time, we have to prepare ourselves that a specimen will not reach within 72 hours. The next thing which we feel limited is that the technique, the test itself do not require viable bacilli, but still we have to transport the specimen in cold chain because of the time time in the transits. And then the transfer of the cool boxes back to the health facility doubles the cost and slows the process. And widely covered National Postal Services, as I mentioned earlier, is not utilized because of the infective material. Because their presence is also at the sub-district level. So this is just a future need of testings, what testing would be required and how much specimens would be needed to transportation. So if we see, at the moment we are diagnosing 24% of the DRTB cases. So if we target that we diagnose 80% of the estimated DRTB cases, that would come to around 8,000 MDR patients. And that would mean that 192,000 only cultures would be required for monitoring of these patients. And we anticipate that 50% of these would require transportation if we assume that 50% would be at the same facility. Similarly, for the universal DST, we have around 350,000 cases are notified. If we assume that excluding the extrapulmonary, we just only think of 280,000 pulmonary TB cases, then also half of these would require transportation for testing. Then our B positive cases are 50% at the moment, and 50% are clinically diagnosed. If we want to improve, then we have to test more suspects. And if we come to suspects, that means that for every case diagnosed, we would have to test 10 cases. And again, this would add to the number of specimens which need to be transported. So what we see as a way forward is what can facilitate the process of specimen transportation, that we need a specimen transportation. Without this, we cannot provide access to diagnosis to all the populations. And we need to take advantage of the molecular technology which don't require viable bacilli. So what we see that specimens which are being transported for the culture and DST, we need to reduce the transport time, and we need to simplify the specimen transport. We need to eliminate the need for cold chain, and we need to add some additive or preservative which could maintain the viability of MTB for up to a week, and which should work well with midget solid culture and molecular. For the group of patients who need Xpert testing, We also need to reduce the transport time, and we need to simplify the specimen transport. We need to eliminate the cold chain, and we need to make specimen transport more biosafe, and so that we are able to ship them. We can also use other postal services by making specimen non-infective. And we also need to simplify the shipment needs, which at the moment, sending it in a transport box and then getting these transport boxes is very tedious. And then thank you, and I'm thankful to the Global Fund, for which is mainly all the budget for the specimen transport and scale up of the laboratory network is funded through the Global Fund. And of course, to the TB culture and DST laboratories, which provided all this data of the specimens which were received through transportation.
Great. Good evening, everybody. Thank you for coming to the evening session, and also to the organizers for inviting me to come. So what I'd like to share with you in the next 15 minutes are challenges and proposed solutions to increase TB case finding and diagnostic accuracy. I am the project director for the USAID Control and Prevention of Tuberculosis project. We call it CAP-TB. We implement in 3 countries, China, Myanmar, and Thailand, but for tonight I'm going to be focusing on our China implementation. So in terms of challenges for TB diagnosis in Yunnan province, which is where we focus, there are, I would say, 2 primary challenges. One is to improve case detection among specific risk groups, specifically people living with HIV and diabetics, as well as in high prevalence areas of the province, Yunnan province. The second major challenge is to improve diagnostic accuracy. As in many other places in China, there is a very high smear-negative proportion of cases among pulmonary TB patients in rural Yunnan. It's actually a very complex problem, which I think will require quite a lot of work to solve, but this is actually one of the main challenges that we face. There's also very heavy dependence on radiology, on X-ray and CT scan. That's usually the primary way, actually, that pulmonary TB is diagnosed. So to address the first challenge, I'll share with you some of our experience for using Xpert for TB diagnosis among people living with HIV. The Xpert machines, of course, have been in China for several years, but its use for case finding and for diagnosis of rifampicin resistance among the HIV population is not a part of the health policy. So what we wanted to do is actually generate data that we can hopefully present to the national level, so that utilization of this technology can be standardized and scaled up throughout the country. So here's a little bit about Yunnan province, so you have a general idea of the context. The cumulative number of HIV/AIDS patients as of the end of October 2015 was over 87,000, so it's the highest number in China. The population of Yunnan, just so you know, is 46 million people. The number of newly reported HIV/AIDS patients from January through October of 2015 was nearly 10,000. In 2011, there was a simple survey of 150 patients with opportunistic infections, and among those, 43% of the patients had pulmonary or extrapulmonary TB. One of the biggest challenges is a very low proportion of AFB smear or culture positivity among the TB cases diagnosed. So it was within this context that we started working with the Yunnan AIDS Care Center, which is the main HIV inpatient hospital for the province. So this was actually not a research study, but rather they had recently installed a Xpert machine, and the doctors within the hospital just wanted to know how to use it appropriately. So we trained the physicians to conduct the TB symptom screening. Oftentimes, symptom screening is not done routinely. And then piloted a multi-method integrated diagnostic approach, which included symptom screening as well as microbiology, smear, culture, and Xpert, and radiology. In actuality, many of the doctors just ended up doing the routine algorithms. So even though we had an algorithm that we wanted them to follow, they kind of did their usual practice. So here's what we found. Patient clinical characteristics. The total number of patients who were tested using this multi-method approach was 800. As you can see, 57% heterosexual transmission in the upper left graph. The gender split is on the upper right with 70% male. The mean age was 42. You can see the distribution there. And the CD4 count for 606 of the patients, it was bimodal in distribution, as you can see. 31% less than 50 and 34% greater than 200. So here I'm just going to show you one slide showing the data, which basically kind of confirms what, the problem that we know existed. The smear and culture positivity was actually quite low. Those are the bottom two rows. So only 8% smear positivity and 3% culture positivity. Now, symptom screen, which is on the top row, is 44%. X-ray CT scan, of course, was very highly positive, 80%. Lots of patients had abnormal X-rays or CT scans. And the GeneXpert test was positive for MTB in 28% of the cases. So certainly better than smear and culture, but not quite as sensitive, if you will, as the CT scan. So there's still a lot of work to be done, for sure, but this was just the first step. This was something that we did over a period of 6 months over the past funding year. There's a large proportion of patients who are still diagnosed with TB using radiology alone in the HIV population. So among the 200 patients diagnosed with TB, 175 of them had pulmonary TB or both pulmonary and extrapulmonary. So here you can look at the split of these 175 patients. 71% in the orange were diagnosed by radiology without lab results, a total number of 125. The laboratory diagnosis, which included Xpert, smear, or culture, was only for 40 patients, or 23%, and then a small proportion clinically diagnosed. So this is really just the first use, actually, of the GeneXpert in Yunnan province, and we still have a lot of work to do, but we're excited that at least it's being used, and it looks like it's even though there's more work to be done, it's an improvement on the baseline. Okay, so now switching gears a little bit, I'll talk about improving diagnostic accuracy and some of the challenges that we face in Yunnan. This is a map showing case notification for the province. Kunming is the capital city in the province, and as you can see, actually the case notification is actually not that high for Kunming, with the blue color in the middle. In contrast, in Zhenshong County, which is a very rural, very poor county, one of the poorest counties in the country of China, it has the highest case notification in the province. In the year 2013, over 2,200 pulmonary TB cases were notified. So just to give you some context for the TB epidemiology here, the China TB prevalence as of 2014 was 89 per 100,000 and an incidence of 68 per 100,000. Now in Yunnan, actually a prevalence survey has not been done for over 20 years. So we don't have prevalence data, but rather we use case notification as an estimate. So at the provincial level, the case notification is 55 per 100,000, whereas in Zhenshong, this particular county, that's what we're focusing on at the moment, the case notification is 158 per 100,000. Now, one of the major issues in Zhenshong actually is a very low proportion of smear positivity. So 21%, only 21% of the 2,200 patients were actually smear positive. So the question here is, are we underdiagnosing the real TB cases, and are we overdiagnosing people who don't actually have TB? The second challenge here is that among the 480 smear-positive cases, 43% of them were retreatment cases. So the question here is there a high risk and a high proportion of MDR-TB in this population? So the China provincial and county system is actually quite vertical, not surprisingly. And what I'm showing you here are the 3 levels of the system, of the health system in the rural area of China. So in Zhenshong County, we have a population of 1.5 million people. TB diagnosis, which currently has been smear and culture, is only done at the county level. Within this county, there are 28 townships. And within each township, there are approximately 9 villages. The population in each village is approximately 6,000 to 10,000. In each of the village clinics, there are approximately 600 clinic visits per month, and 10% of those visits are for respiratory symptoms. Now, in terms of challenges, number 1, sputum smear is only available at the county level, while patients often present to the township or village level when they have symptoms. To get a patient from the village level to the county level is actually quite difficult. The roads are very underdeveloped. In the wintertime, it's very cold with snow and ice on the roads, and so actually getting a patient from their home to the place where they can actually get diagnosed is very challenging. Culture, number 2, culture capacity previously was only limited to 30 samples per year. This was because the province, at the provincial level, they provided LJ media at the county level, and they only received 30 per year. It's now increased, but culture still has only been done for smear-positive cases, so for the diagnosis of resistance as opposed for case detection. And the third challenge here, which I've mentioned, is the high proportion of smear-negative TB. So what are we proposing to do? In terms of the first intervention, increase accessibility to sputum smear in order to improve case detection, transport sputum from the village to the county level, as opposed to transporting patients. Number 2, a Genexpert machine was just recently installed as of last month at the county level in Zhensheng. And also we're hoping to develop, well, actually we're not hoping, they have been working on their culture capacity with the goal to increase both TB case finding and as well diagnose RIF resistance. And number 3, for the high proportion of smear-negative TB cases, this is quite a complex issue, as you might imagine, because we're dealing with probably poor sputum quality sample, a heavy dependence on CT and X-ray, likely overdiagnosis of TB, and then kind of poor decision-making among the doctors who actually up until recently were not aware of the fact that the high proportion of smear negativity was a problem. So for this challenge, what we're starting is monthly case review to track concordance among the different diagnostic methods with the goal to build capacity for diagnosis. Okay. I'm actually moving quite fast. So taking you back to the very first slide when I talked about the different challenges and solutions, really there are 2 major categories. One is improving case detection, and the second is improving diagnostic accuracy. So with respect to our proposed solutions, we want to improve capacity at the county level for diagnosis and improve accessibility to lab testing through sputum transportation from the village level up to the county level. We haven't actually started this yet, so as in contrast to the presenters who have gone thus far, I'm talking to you about proposed solutions, and we're actually about to start this within the next month. In terms of improving diagnostic accuracy, we would like to see the integration of molecular diagnostics, specifically the Genexpert, with existing lab methods, radiology, and clinical methods. Like I said, actually, this issue of high proportion of smear negativity is not unique to this province and certainly not unique to this county. There are some provinces in China where I think the proportion of smear positivity is very, very low, like 20%. So I think it's not going to be a simple solution, but certainly we would like to start tackling the problem. And then number 3, improve upon the specificity of X-ray and CT scan for diagnosing TB. It's too sensitive, not specific enough. And improve upon the sensitivity of smear and culture so that we can have better data to support the diagnoses. So with that, I will conclude, and thank you. We have actually quite a lot of people. I'm not giving you any details actually about the CAP2B project, but we have a lot of local partners. We work very closely with the government, and I have a lot of people to thank, including the donor, USAID. Thank you.
Okay. I would like also to thank the organizers for this opportunity. My talk is really focused on challenges we are facing in Cameroon to increase or to ease access of more TB patients to the new diagnostic tools. So Cameroon is a Central African country. Population is estimated over than 20 million inhabitants. TB burden as well as TB/HIV co-infection are relatively high. So we are notified, we have 26,000 cases TB per year, and more than 15,000 are microscopy positive. And TB co-infection is still really high. It varies according to the region from 30 to 60%. So the 2 main cities, Douala and Yaoundé, are reporting more than 1/4 of all cases in Cameroon. So what about our TB network? So Cameroon is organized in 10 regions, limited like that. So in 1997, we implement the first national reference lab in the capital Yaoundé with facilities of culture and DST in solid media. Later on, in 2000, we implement a reference regional lab in the north part due to the distance, and we implement there only facilities for solid culture, and positive culture were sent to the national reference lab. And in 2010, we got the support from Xpert MTB program, and this support helped us to settle in another reference lab in the northwest, not in the west, in the northwest, the Bamenda Regional Lab, with the same facilities that the National Reference Lab. So we are able now, with 2 labs, to do liquid culture, to get liquid culture and drug susceptibility testing, always at LPA, Xpert, and only in the reference regional lab in the north part, we are continue only with solid culture due to the infrastructure constraints. We were not able to also settle the liquid culture, but we introduced 4 modules for Xpert. The regional reference lab in Bamenda is currently going on with a TB-REACH program, and installed there more than 7 other instruments and 18 modules, because this region have the highest co-infection TB, HIV, around 16%, and they are going there, running there a program to increase the detection cases. The National Reference Lab are going on with other projects, but we are also evaluating alternative tools for diagnosis like TB lamp, slide DST, or fluorescein diacetate. Overall, our network is comprising 238 basic management units, 10 regions, but the 10 regions are now organized in 3 zones, covered by each of the reference laboratory. So the reference laboratory in Bamenda is covering this part. The National Reference Lab is covering these 3 regions, and the North Reference Lab is covering 3 other regions. But despite this organization, we are still facing many challenges to increase the access of patients to culture and experts. Mainly for MDS suspected cases, we are supposed to have culture for each suspected cases. So what are the main challenges we are facing, and also how we try to move forward? So the first challenges, as already mentioned, is the weak sample transfer. So we really face challenges for sample transfer. The National TB Program has organized through a kind of courier system, but through the public transport, and have appointed a local person at each level so that we minimize or we avoid the transport of the patient and only send samples. And there is also a phone network to advise when the samples are sending. But so for solution, we are now decentralizing experts in each region. This is already going on through the help, also the support of Global Fund. And we need also to reinforce our North Regional Lab so that we will not send solid culture, positive culture in the National Reference Lab to reduce the delay of detection. There's still delay in delivering results. Despite the mobile network, the email, we have to send results through the National TB Program. So what we are proposing is to have an IT platform we have the pilot one. So since 2 years ago, WHO support us to implement an electronic platform based on an open sources, and it was really designed, it was customized to what we need in the country, and is designed to be accessed at each level of the region. So the pilot phase, I think the WHO presented last union meeting, the pilot phase is already going on now, and we have the National TB Program has to take the program to appropriate it and extend it to all the regions so that we could have access of, each region could have access to the data. Union have also just installing now the Xpert exchange so that all Xpert data could be available at the National TB Program level. So the new tools we are using are costly, and safety, there are many safety requirements. And these all new tools are rely on external funding. The supply chain is rely on external funding. So we really need the National TB Program to sustain. So the government has to sustain what we have already implemented through the external funding. And I think at the level of the national reference, we have also need to evaluate or see how to introduce non-commercial methods which seems less demanding like MERTS, slide DST of FDA microscopy. So one of the other challenges was the training of the medical staff. As soon as we introduce a new tools, we need also to train those who are those who have to interpret result or know how to use the result. So we get also funds from FINE to organize workshop on sensitization of clinicians and the usefulness of Xpert. And I think it was really a good experience. And we have to think about this kind of training also when we introduce other alternative methods. So that I have listed here some of the challenge and the way to move forward. So thank you.
What you can summarize from this, some common threads, and I'd like to point out just 3 of them. And the first one would be right at the point of collection, specimen collection, of the good quality specimen collection, and that will involve the training of the healthcare worker, as well as a good sort of medium of storing that specimen during its transportation because of many challenges like long distances, turnaround times to get the laboratory and high temperatures. And I think the very big thing is that if you have state-of-the-art assays with state-of-the-art laboratories, if you don't improve behavioral changes on ground within the facility, none of the assays will be that sensitive. So I think that's a challenge for all countries. The biggest one I see is algorithm adherence, sticking to the algorithm of a national TB program and retraining of that.
Thank you very much, everyone.